Thank you all for coming, and we're thrilled to see this wonderful turnout for our quarterly Prenatal and Infant Care Network event, which we affectionately call PIC. I'm Meg Disler. I'm the Executive Director of the St. Joe Community Health Foundation and your host for today. Just a few housekeeping notes before we get started. Our gratitude first to the University of St. Francis for allowing us to meet here today. And after we hear from Dr. Dungy-Poythress, and we're going to take some questions at that, so please hold your questions unless you have something and she instructs us otherwise. But we will have some refreshments in the gathering area. We invite you all to stay and get to know each other and maybe talk a little more about this work, any of your work in prenatal and infant care, or anything you heard, because so many of the people in this room are making a difference on the front line. For those of you who are unfamiliar with the work of the St. Joe Community Health Foundation, let me take a moment and just tell you briefly who we are. We are a ministry sponsored by the Poor Handmaids of Jesus Christ. They are a religious order of Catholic sisters who founded St. Joe Hospital back in 1868. And they've also founded many other ministries in this community in the last 155 years. Outside of the St. Joe Community Health Foundation and other ministry of the Poor Handmaids is Health Visions Midwest of Fort Wayne. And we're happy to have members of their team with us here today as well. All of our ministries are inspired by Jesus Christ and God to make sure that no one in our community, especially the vulnerable, are left behind without access to quality health and wellness care. The St. Joe Foundation was reorganized in 1998 when the Poor Handmaids sold St. Joe Hospital. We focus primarily on supporting and strengthening our community partners, many of whom are in this room, who provide direct services to vulnerable people in our community. We've awarded more than $25 million through 1,700 grants to almost 300 different organizations here in Allen County in the last 25 years. We work in 4 priority areas: food insecurity and nutrition insecurity, immigrants and refugees, access to a quality and affordable health care, and obviously today, prenatal and infant care. Within our prenatal and infant care work, we facilitate the PIC, or the Prenatal and Infant Care Network, to provide quarterly educational networking opportunities for us to come together as a community to figure out how can we do the best work we can in this area. We're blessed with a great steering committee for the PIC network, and includes directors from the Women's Care Center, Parkview Health, Macmillan Health, Lutheran Social Services, the Lutheran Health Network, Neighborhood Health Clinic, the University of St. Francis, Healthier Moms and Babies, a Hope Center, DuPont Hospital, Dr. Laura Overton, among others. But that is who help guide our work in this area. Why do we need a prenatal and infant care network? We all know that unfortunately not all the mothers and babies are getting the care they need, and together we're trying to change that. As most of you know, too many mothers and babies are dying here in Indiana and locally in Allen County. The numbers in our state and county are higher than the national average and higher than many developed nations. And that is there's a startling difference in the numbers when you look at race. Nationally, Black women are 3 to 4 times more likely to die during or within 1 year of the end of their pregnancy. For Black women in Indiana, the maternal mortality rate is 93% higher than the rate for white women. It's frankly just unacceptable. We are grateful to have an expert in maternal fetal medicine with us today to help us better understand what's happening and how we can work to address these inequalities in our community. Dr. Lauren Dungy-Poythress joins us today from Indianapolis, where she's an associate professor of clinical obstetrics and gynecology at Riley Hospital for Children at IU Health. She earned her medical degree from the University of Michigan's Medical School. This was followed by residency training in obstetrics and gynecology in Ann Arbor, Michigan, and a subspecialty training in maternal fetal medicine at the University of Cincinnati. She's won numerous awards, including the International Association of Obstetricians and Gynecologists Leading Physicians of the World Award. My colleague Angela Stanley, who's also circulating around this room, who is also the Foundation's Vulnerable Populations Program Officer, and we heard Dr. Dungy-Poythress speak in December at the Labor of Love with the Indiana Department of Health. So I can assure you, you are in for a wonderful, informative, inspiring presentation with her. She shares with many whom she's consulted with around the country. So with that, I would like to welcome to the stage Dr. Dungy-Poythress.
I just want to thank the St. Joseph Community Health Foundation and Angela and Meg for inviting me here. I am thrilled to be here, thrilled to open up a dialogue and discussion about this topic. And I just had a wonderful breakfast with a group of charming and committed individuals. So I'm really excited to be here today. I'm going to ask you one thing. I tend to walk when I speak, and I tend to speak from my slides. So I'm going to be turning to look at my slide to talk. If you feel like I am getting dangerously close to this edge, somebody just yell out before I fall off, okay? So we'll just go ahead and proceed. So I'm going to talk about perspectives of implicit bias and then how it relates to maternal health care. What is implicit bias? I want you to imagine that you just came out of a freezing rainstorm and you walk into a room, and on the left there's a blue fireplace and on the right there's a red fireplace. You have to decide in a matter of moments which one you're going to walk up to. And you're going to use your implicit biases or your understandings of what you know about blue and red fireplaces to determine which one you're going to walk up to. And you may say, I have never seen a blue fireplace. There's no way that's going to keep me warm. I'm going to walk up to the red side. Or you can say, I'm very familiar with the red ones. I like the red a little bit better. But you're going to make a decision based on the implicit biases that you have in your mind. And that's what implicit bias is, the ability to rapidly categorize every person or thing we encounter, and it's thought to be an evolutionary development to ensure survival. Humans needed this in the past to quickly decide whether something or someone was dangerous or friendly. Our brains still use these shortcuts. If a tiger jumps through the wall, I've got to quickly decide, should I stay here and try and pet it, or should I run through that door over there? So we're going to use our knowledge, our implicit biases. We're not really going to think about it. We're going to act quickly based on what our beliefs are. Unfortunately, sometimes our implicit biases are used as a detriment to others. Our attitudes, thoughts, and feelings that exist outside of our conscious awareness is what implicit bias is, and therefore it's difficult to consciously acknowledge and consciously control because by definition they're unconscious, they're implicit biases. These attitudes are often automatically activated and can influence our human behavior without our conscious volition. So why do we care about implicit bias in healthcare? Implicit attitudes about patients may contribute to disparities in healthcare outcomes. There may be attitudes that are based on racial backgrounds, gender, disability, socioeconomic status, obesity, and other factors. And professionals may say, you know, we treat everybody the same. We try to treat everybody equally. We don't hold negative attitudes about patients, but by definition, these implicit biases are unconscious and we lack awareness of them, and our actions may often unknowingly suggest that these biases are active. Unfortunately, too, these biases may lead to covert discrimination and institutional bias that can be sustained throughout history by our subtle implicit attitudes that influence provider behavior and treatment choices. I like to give an example of when I was a resident back in Michigan. There was a doctor who we always enjoyed operating with because he always had nice, thin patients. You could operate very easily. He never had an obese patient that can be a little bit more challenging to operate on. And then we all found out, he had a chair in his waiting room. And if the women couldn't fit in that chair, they couldn't be his patient. And that's why we all he always had these thin patients to operate on. You may have seen there in Columbus, Georgia, there was an article that I read in the paper one day that had a picture that had a sign in a OB-GYN doctor's office that said, if you wore a bonnet in as a patient, you couldn't be seen. We all, maybe we don't all know, but I know the kind of patients who are going to wear a bonnet into a doctor's office or wear it outside of their house. I sleep in a bonnet to protect my hair. I don't wear it out during the day, but there are certain populations of patients who do. I don't like the look of it necessarily. I don't like my daughters doing that, but I'm not going to refuse you treatment simply because you wore a bonnet into my office. We also might see pictures in advertising when you walk through a hospital. Do the patients or the pictures on the wall reflect who you are? Or do they reflect people of other cultures? And do you feel comfortable walking through that? So you may have heard of the implicit aptitude test. It was developed back in 1998. It calculates how quickly people associate different terms with each other. And they have pairs, and you have to quickly decide which one pair you're going to choose based on different topics. I encourage you to take one, if you haven't, just to understand what that process is. But, for example, they may sort pictures of black and white people with words like good or bad into pairs. And by looking at the picture, you had to decide, should this go in the good column or in the bad column? And based on the reaction times needed to perform these tasks, the software calculates a bias score. Now, a lot of people have discussed limitations and criticisms of the implicit aptitude test. And while we recognize there may be limitations and criticisms, critics don't refute the existence of unconscious bias or that it can influence life experiences. When you look at the implicit bias, Project Implicit Bias by Harvard, that race implicit aptitude test has been taken more than 4 million times. And out of that testing, they have identified that 75%, a vast majority of test takers demonstrate an automatic white preference, meaning that most people, including a small group of black people, automatically associate white people with goodness and black people with badness. So to the extent to which the implicit aptitude test predicts behaviors is unclear, but the preferences can certainly be identified. Now, these preferences do not necessarily mean that an individual expresses outward expressions of racism, but they do identify a bias. So I want you to look at this video. What did you notice? Did the girls, you noticed two girls, a black girl and a white girl? Did they look like they were about the same age? they look like they were wearing the exact same clothes? What was the difference between those two scenarios? Beg your pardon? The race and the attention that the young white girl got and the concern afforded her with the lack of concern afforded to the young black girl. When I have shown this in the past, people have said, well, the black girl looks older than the white girl. They're both the same age. They're both 6 years old. I just want to make sure this keeps going. Excellent. So we'll come back to that. But it does show a bias. I'm not saying that people didn't care about that, are uncaring, who didn't approach the young black girl who was standing there by herself to see if she needed help, but there was a bias that allowed people to more comfortably approach the young white girl to address what, if any, help she might need, despite the fact that they're the same age and wore exactly the same clothing. This is a diagram of a study that was looked at implicit bias in childhood, and these biases, as I'm going to point out, extend into adulthood. Researchers led by Yale professors showed 135 educators videos of children in a preschool classroom. There are groups of 4, 2 boys, 2 girls, 2 black, 2 white. The teachers were asked to detect, quote, challenging behavior, unquote, and they were given examples of that. But by definition, and to be clear, there was no such behavior that existed in any of the videos. Yet, when asked which children required the most attention, 42% said the black boy, followed by the black girl, followed by the white boy, followed by the white girl. And then when they did independent eye tracking technology, they also noted that these soon-to-be preschool teachers showed a tendency to more closely observe black students as opposed to white students when they're asked to detect challenging behavior. There is a reference there, I realized. I don't know if you guys can see it. I can't see it from here, but I can see it on that slide back there. This is another study that looked at implicit biases in childhood. And it showed that new teachers mistakenly assume black students are angry. 72 black and white child actors, trained by experts to make some specific facial muscle movements. And to be clear, they were absolutely trained to make the very same facial muscle expressions. Teachers in training watched the videos of the children and were asked to identify the emotion they saw. The study showed that more than a third, 36%, were more likely prone to mistakenly see anger where none existed because they were all making the very same facial expressions. Yet 36% of them said that the black children were angry. The research also demonstrated that black children are viewed as 4 to 5 years older than they are, which might explain why some people watching the video of those 2 girls said, well, the black girl was older. She didn't need as much help as the white girl who was standing there. It also might explain that previously researchers had determined, these same researchers had determined that college students who aspired to become teachers were more likely to misread black adults' emotions as compared to sensing what white adults are feeling, and that they mistakenly believe that black adults are angry when they're not feeling any anger at all. And this study showed that teachers are prone to mistakenly seeing anger where none exists in children, black children as well. And that it starts way before they even hit kindergarten. That might explain why black children are 3 to 4 times more likely to be suspended or expelled from school than their white classmates, and why black children tend to feel less understood by their teachers than white children do. The potential consequences of poor relationships between students and their teachers and school discipline can be long-term and last well into adulthood. That might also explain why this young girl right here, who is 6 years old, is being arrested, handcuffed, and arrested, taken to the police station for what was described as throwing a tantrum in her kindergarten class. The news article stated that the fellow police officers shared concerns during this Orlando's officer's handcuffed and arrest of a 6-year-old as to why he did that. It also might explain why this unfortunate 12-year-old boy was shot in Cleveland, Ohio, for playing with a toy gun in a park all by himself. So teachers are not the only adults who mistakenly see black children as angry, who see black children older than they are, and overreact. And sometimes the consequences are tragic. I often wonder, what does this black girl think as she's growing up? Surely she wasn't the only person in a kindergarten class to throw a tantrum. What does she think? Does she think I have to be better than everybody else? I can't do what everybody else is doing, or I'm going to be treated differently. Did she think I'm going to jail, I'm going to be there for the rest of my life, or that I'm such a horrible person because I had a bad day in kindergarten? Unfortunately, we have example after example after example of racism, hate crimes, things where people are dehumanized and devalued. I had this slide when I spoke last year at the Labor of Love Summit. I decided I need to add a new one because there's just more examples after example of hate crimes directed at Native Americans, at Asians, at Pacific Islanders, at people of color. And there may be instances of discrimination not only based on your race, but your religion, your sexual orientation, as well as your ability status and your ethnic origin. There are a lot of factors that affect health. We talked about a lot of them at the breakfast that we had this morning. There are things like, how safe do you feel in your community? What's your education level? Social and service resources and support, employment, housing, transportation, food stability, domestic violence, government policies, income. But there are things like personal experiences, like the 6-year-old girl who got arrested and taken to jail, and what her friends and her family think of when they see police officers. There might be examples of microaggressions, hate crimes, police brutality, things that certainly are predominantly experienced of people that are non-white or people of color. I call all these factors stress factors, and stress, we know, can cause a lot of health problems, high blood pressure, heart conditions, certainly associated with preterm labor, preterm delivery, preeclampsia, and complications of pregnancy. And anything that stresses a woman, if you're a woman of color, you're likely to be stressed even more because you are exposed to situations that people who are of white ethnicity aren't exposed to. There is, I'm sorry that didn't show up there. There's a weathering concept. Can you hear me? Okay. There's a weathering concept that has to do with chromosomes. This is a chromosome up here. And these green areas are the telomeres. And there is a concept called weathering where stresses in life can cause breaks in the telomeres, and these chromosomes become shorter And then when the DNA is read off of them, there's different messages than what was initially intended to be read out. We call that concept weathering, where we can actually tell your genetic age, if you will, your chromosomal age, just based on looking at the length of a telomere. That becomes important because this weathering concept is felt to affect outcomes in health. And the chronic stress that's put on the body, as described by this gentleman here, Michael Liu was a director of maternal and child health for the government. And I love the way that he put it. He said, chronic stress puts the body into overdrive. It's the same idea as if you keep gunning the engine, that sooner or later, the engine is just going to wear out. So chronic stresses that might start back in preschool, of how you might be treated differently, or considered to be angry, considered to be difficult, considered to be a challenge, that go on and are carried into elementary, middle school, high school, as well as life after that, can affect the outcomes and the well-being of women as well as men. Michael Liu said, as women get older, birth outcomes get worse. That happens in the 40s for white women. It actually starts to happen for African American women in their 30s. Studies have shown that in general, and this were studies done a while ago, there's been so much added stress. Maybe that's different these days, but the studies suggest that on average, Black women are genetically 7 years older, chromosomally 7 years older than their white counterparts. We know that more adverse outcomes are associated with advanced maternal age. As he points out, if that happens in the 40s for white women, it happens in 30s for Black women. The stress, in his words, the stress of being a Black woman in American society can take a physical toll during pregnancy and childbirth. And that's where I come in. This is what I do for a living. I treat pregnant women. I look at racial disparities in maternal health. And there's certainly some in perinatal medicine, but there's some outside of pregnancy. We know that Black women, compared to white women, more likely to die from cervical cancer, more likely to die from breast cancer, more likely to die from endometrial cancer. Increased risk for men as well, and women, men of color. And I shouldn't neglect that, you know, if you're Native American or Pacific Islander, they don't even tend to monitor you as well to give us numbers to know what's going on. Asian is increasing. Hispanic is somewhere in between white and Black. There's something about being non-white that increases the risk of complications, particularly in pregnancy, which is the highest disparity in health when you look at perinatal medicine. Preterm birth rates are 40% greater in Blacks than whites. That affords this child that's born prematurely all the complications that can be associated with prematurity and the long-term adverse outcomes. Maternal mortality, as Meg pointed out, is 3 to 4 times greater in Blacks versus white, and here in Indiana, significantly, higher. Severe maternal morbidity rates are 20% greater in Blacks versus white. Readmission to the hospital after delivery, 80% higher in Blacks versus white, and 16% of those have significant morbidity, meaning I didn't die, but I darn well came close to it. So the complications for Black women, and I say Black women because the complications in Europe for Black women, the complications in Germany for Black women are higher than the complications for white women in those countries. They're not African Americans. So I use the term Black because there's something particularly about being Black, as opposed to Hispanic or Asian, that we could have dialogue on what those things are, but structural racism is for real. There's something about being Black that puts Black women more at risk for health outcomes, particularly pregnancy-related ones, than white women. The Society of Maternal Fetal Medicine, of which I am part of that organization, in 2017 issued a position statement and then reissued it in 2020 after George Floyd was murdered. And they emphasized that they strongly encourage maternal fetal medicine physicians to be conscious of social determinants of health and inequality, and to pursue training in implicit bias and cultural humility, and to ultimately work towards a goal of health equity. So that's one of the governing bodies in the organization that I'm in. The other one is the American College of OB-GYN, or ACOG. They put out a statement in 2022. They specifically noted that racism, not race, drives health inequities and leads to adverse health outcomes. Race is a man-made construct. It is not a biological construct. So it is racism and not race that drives these health inequities. And they specifically said that racial and ethnic inequities in obstetrics and gynecology cannot be reversed without addressing all aspects of racism and racial bias. So I just want to give you a few examples of implicit bias in healthcare, and a lot of them come from studies done by patients seen in the ER, or emergency room. Black patients seen in the emergency room departments receive less analgesia than white patients. Hispanic patients, in one study, were 7 times more likely to receive, less likely to receive opioids in the emergency room than non-Hispanic patients, even in the presence of severe injuries. Pediatric patients were often provided, this was a study where pediatricians were provided with identical vignettes, randomly identifying a patient as either black or white, and they underwent implicit aptitude testing. Those providers who had a high degree of implicit pro-white bias were significantly more likely to disagree with the standard of care and provide opioid analgesia to the white patients. Marginalized populations such as the homeless or people of color are often presumed more likely to be non-compliant with their medications, presumed more likely to be medication seeking or having an ulterior motive when seeking care. I often give the example of a sickle cell patient that I had who was at a different institution. Sickle cell anemia, in pregnancy, you're more at risk to have a crisis. They're painful. They can lead to preterm labor and complications. They can lead to significant medical complications. You want to treat them promptly. You want to treat them with hydration. You want to treat them with pain medication. I had a patient who presented to a different hospital in our area, to the emergency room, had all the indices that indicated that she was in crisis. She knew that. They were reluctant to give her pain medication. And they said they weren't going to do that. She left the hospital and came to our institution, where she was admitted and we treated her. And she told me how frustrated she was. You can imagine when you leave one hospital and you go to another or another, you look like you are drug seeking. You look like you are not compliant with what somebody has told you is best for you, when indeed it doesn't feel good for her. But more important, equally important, it's dangerous for her to be in sickle cell crisis during pregnancy without adequately treating her. Dangerous for her and her baby. Might explain why there's more maternal mortality and infant mortality in patients who are non-white. I should say, I also gave that same example to a national presentation that I attended, and we talked about sickle cell anemia, and at the question and answer period, I don't think I got any questions. I just got example after example after example of women telling me how they've been in the, women of color telling me, the whole audience, how they've been in the emergency room and denied medication for different examples. A couple of them had sickle cell anemia. One patient who, amusingly enough, was the civil rights director for her community. And she said, she had some kind of gallbladder condition. She said, I'm laying on this dirty ER floor, and the doctor's trying to talk to me about how he can't give me any pain medication, until she happened to mention she was the civil rights director for the community. And suddenly, oh, okay, well then suddenly she got pain meds and she was treated more compassionately. NPR, Harvard, and the Robert Wood Johnson Foundation did a survey in 2017 where they talked to Black women, and they found that problems are amplified by unconscious biases that are embedded in the medical system, affecting the quality of care. Over a third of Black women said that they had been discriminated against because of their race when going to a health doctor or clinic. And 21% said that they had avoided going to a doctor or seeking health care due to concerns of racial discrimination. We often talk about access to care as an issue in perinatal medicine, and that if we just could make it, if we could help these women get into care. Well, I always say, well, why aren't they coming? Do Black women not care about their babies? Do Hispanic people not care about their babies and being pregnant? What is the reason behind why I would wait until my third trimester to come into care if I thought that it would be better for me to come in earlier? Are there obstacles that make it more challenging for me to get into care? And then do I feel marginalized or dehumanized when I do come? And I just don't like feeling like that. So I'm not going to come in right away till it's absolutely necessary. Mark Morial is this gentleman down here. If you can see his picture, he was the president and CEO of the National Urban League. In 2022, they do a quality index every year. But just last year, in the Equality Index, he expressed that Black Americans are, quote, frustrated and worried about being discriminated against because of their race, and that Black Americans particularly feel the sting of racism in the healthcare system. And the index revealed that an overwhelming 8 in 10 Black respondents feel that race influences the quality of care a person receives. This gentleman here is Senator Bill Cassidy from Louisiana in 2021-22. Their state at that time was at the lowest for maternal, the worst, I should say, for maternal mortality. And he was asked the question, why was that? And his answer was, well, you sort of have to understand about a third of our population is African American. African Americans have a higher incidence of maternal mortality. So if you correct for our population, basically if you ignore all the Black people, we're not doing so bad. We're really okay. For whatever reason, he says, whatever reason, Black people just don't do as well. This is Serena Williams. She had a history of a pulmonary embolism, a blood clot in her lung. Blood clots in your lungs can kill you. She had that before she got pregnant. Pregnancy is a risk factor for pulmonary embolism. A prior history of pulmonary embolism is a risk factor for pulmonary embolism. She had a C-section. C-section is a risk factor for pulmonary embolism. So she had 3 outstanding risk factors for pulmonary embolism. Felt like she had a pulmonary embolism, short of breath, uncomfortable, went to her nurse and said, you need to call my doctor, I need to be on heparin right away, I need a CT scan. And her nurse said, oh, you just had a baby, I think the drugs are affecting you. She placated her and tried to ignore her. Now, I heard different stories on this, but I heard that she called her agent and said, get me out of this hospital. And then things started to happen, and they get her the CT scan, put her on heparin. She does have a pulmonary embolism. She has lots of complications after that related to it. But I cannot imagine that I have a patient who says to me, it feels like I had a pulmonary embolism when she had one in the past, and I don't do everything to evaluate for that because she's certainly at risk. And I cannot imagine that I'm going to let Serena Williams die on my watch as me as the attending physician. She's pregnant now. I wonder who she's going to, and I just wonder, what their plan is on the postpartum management. This is Shalon Irving. She was a lieutenant commander in the U.S. Public Health Service, PhD, MPH, MS, CHES. She was highly educated. She's not an uneducated person. She had Gold Star CDC insurance. She, as a matter of fact, studied racial disparities for the CDC. She had a C-section at 37 weeks because of a previous fibroid surgery. 2 weeks after surgery, she noted that she had some incisional pain and some drainage. So she went in to her doctor's office, didn't see her primary physician, saw somebody else who looked at her, I guess looked at her incision and said, oh, you look pretty good, you're okay. Go back and come back later for your routine visit. On the way out of the door of the office, she passes her primary physician who says, you look like garbage. What's going on? And she tells her what happened. She brings her back in. Her primary doctor looks at her incision, sees this drainage and concern, opens it up. She's got an infection. So she now needs to have a visiting nurse come and visit her to help pack that incision and see how she's healing. And while she's seen by this home visiting nurse, she has a blood pressure of 174 over 118. 160 over 110 is considered severe at risk for having a stroke. So the visiting nurse tells her she should go in and be seen by the doctor. She doesn't go the next day because it's a big hassle and she's been treated sort of marginalized when she's gone in there before, but she does go in the next day. When she's seen in the doctor's office, her blood pressure is lower. They do some labs. They tell her everything looks normal and they send her home. 5 days later, she returns. She's had a 9-pound weight gain in 10 days. She has edema up above her knees. So if you don't know, it's normal to have a little bit of edema in your ankles, but if you have swelling in your legs all the way up to your knees, you might be in heart failure. That is not normal. That should not be dismissed. She told them, I just don't feel well. And they tell her, you just had a baby. Give it time. They send her home. 3 weeks after delivery, they decide that she does need treatment for hypertension. She goes with her mom to her doctor's visit. On the way home, they pick up the medicine at the pharmacy. They then went out to dinner before getting home. After they get home, her mother is putting the baby to bed, and her mom describes that her daughter says, I don't care what they say, I just don't feel right. Then she has a cardiac arrest and she collapses. She dies later at the hospital. Hospital says this is not unusual. This is a normal thing for delivery, and they refuse to do an autopsy. So the mother has to take her daughter to a different county and pay $4,500 for an autopsy in another county where they find hypertensive disease of the heart as a cause of her demise. I should say, too, during her pregnancy, her best friend describes how she was so anxious during pregnancy because she knew she was going to have a male baby, and she knew that black males in this society sometimes are targeted, and she was very anxious about that. This is Charles Johnson. His wife, Kira, died 10 to 12 hours after what was described as a botched scheduled C-section. That C-section was in and out in 17 minutes. That is remarkably fast for a C-section. Initially, I thought, oh, there was some fetal distress. They had to get in. They were in and got the baby out in 17 minutes. They meant they were in, take the baby out, sew things back up, and she was headed to the recovery room in 17 minutes. That is remarkably fast. She was noted, her husband described how he noticed some blood in the catheter. She was having a repeat C-section, by the way, so they've seen this before. There was never blood in the catheter the last time. He brings it to the nurse's attention. At some point, there's some discussion about ordering a CT scan. They're going to do that stat. You just have to listen to the video and hear him describe how his wife would shake and shudder. She was there hour after hour after hour, no CT scan, no further evaluation. When they finally did take her back to the OR, some 12 hours later, she had 3.5 liters of blood that was free in her abdomen. That's more than half your total blood volume. So she had bled outside of her vessels, so not much is getting to her heart and other organs, and it's all just sitting in her abdomen. When they opened her up, she had a cardiac arrest and she died. He, as a husband, tried to advocate for her on her behalf time after time throughout the day, asking, where's the doctor? Why aren't we having a CT scan? It was supposed to be stat. What's going on? At one point, he says he was told by the staff, your wife just isn't a priority right now. And what is disturbing to me is that throughout the course of this day, Kira, his wife, repeatedly asked him to calm down because she was afraid he'd be labeled as an angry black man. I tell people, she must have looked like she was dying. She must have felt like she was dying because indeed, for 12 hours throughout that day, she was dying. And I tell people that I recall being in my 20s. I recall thinking about who I would marry. I recall thinking about having children. I never once thought, I don't think I'm going to have children because there's a higher risk for me to die. I never once thought, I'm not going to have children because I might be in the hospital and they might just ignore me and watch me die. And I unfortunately have had black young women say to me, I don't know that I'm going to have children. This is crazy. 3 to 4 times more likely to die because I got pregnant? I just don't think I'm going to do that. Charles Johnson sued Cedars-Sinai Hospital, citing racism as a cause of his wife's death. I sometimes give lectures for sociology classes, and one of the students there said, well, you know, hospitals are really busy. It's probably just they were just too busy. They were going to get to that CT scan. They're just too busy. Nurses are overworked. I said, you know, to be called a level 2, level 3, level 4, there are criteria for that. And if you don't have the nursing staff to treat each patient, you can't be established that way. But nonetheless, what did it take to identify? What had happened was when they did this rush job on the C-section, they nicked her bladder. That's why there's blood in the catheter. That's why there was blood going into her abdomen. And she sat there all day and bled to death. She must have looked like she was dying. She must have felt like she was dying because she was dying. W.E.B. Du Bois said in 1903, the problem of the 20th century is the problem of the color line. The relation of the darker to the lighter races of men in Asia and Africa, in America, and the islands of the sea. 1903, he said that. Indeed, we do have some issues of color in the color line here. You can read about racial identity development. There's different models out there. I just put this together sort of with some thoughts that I have. And they go through different levels, but we all sort of start out with this naivete that we're all, you know, sort of colorblind, sort of equal. Then you get to be 3 and 5 and you sort of conform, but it's different for white people compared to people of color. And you might go through stages of you know, yeah, just get over it. We're all here together. We're just, you know, doing things, and it's been there a long time. Let's just do the best we can to then, I feel guilt and shame because there's issues of racism, and yes, I recognize my white privilege, and if you're a black person, you may be angry and bitter, or if you're a person of color, you might be disillusioned. What can we do? This has been going on so long. But you hopefully progress. And it may not be a straight path. You may loop up to one, loop back to the other. But eventually, we all want to reach a goal where we reach this integrative awareness. We both have an understanding. It is what it is. It's not, you know, we are who we are. God made you white. He made me black. You know, what is that? Doesn't mean we can't work together. Doesn't mean we can't make this world a better place. But you might be like me and get a little disillusioned. I tell people after the murder of George Floyd, I was done. I told my husband, I'm done. I looped way back down here to dissension, disillusionment, a little bit of angry, bitter, hung out there for a little while, and then moved back towards my goal of integrative awareness, where we can all work together, make this place better for everybody, because my 2 daughters deserve it. All of your daughters and sons and their children deserve it. So we can't get stuck in any certain area. We have to be like a shark and keep moving forward. So why do we care about implicit bias in healthcare? Because it can compound social stress factors affecting health and contribute to racial health disparities. And that may be better understood as a cognitive manifestation of historical and structural and organizational inequalities rather than solely a feature of individual mindsets. So it's not just, I've got to change your mind, I've got to work for social issues across this country and certainly in our individual areas to make a significant impact. It suggests that efforts to remediate implicit bias require attention be given to modifying social environments and not solely to changing the attitudes of individual attitudes. So whether bad or good, justified or unjustified, our beliefs and attitudes can become automatically triggered, affecting our behavior and decision making. It can happen unintentionally, unconsciously, without effort, and in a matter of seconds. It can happen irrespective of our values and irrespective of what kind of person we want to be. I often describe to people that because of that, we have to have ongoing efforts. It can't be, we had an implicit bias training in our office today. We don't have to do another one for a year. It can't be that there's not different ways to look at implicit bias or to understand our conscious and unconscious biases. I often liken it to a 2-minute drill in football. A championship team is not going to do the 2-minute drill just once a year in a practice. They're going to do it every week, if not every practice, because when it comes down to the critical situation, when there's only that 2 minutes left, if you haven't practiced it, if it hasn't become habit, you will revert back to your old habits, no matter how well-intentioned you may want to be. And that's why it has to be ongoing. We all have implicit biases. We all need to address these issues. So the efforts to mitigate implicit biases that can negatively affect healthcare require deliberate intention, focused attention, persistent mindfulness, and it has to be on both an individual and an organizational level. This quote from Sarah Fryerman says, deconstructing our unconscious bias takes consistent work. We can't address it once and be done. We need to recognize these unwanted, deep-rooted beliefs and limit their influence on us. I especially like this quote that says, the only thing necessary for the triumph of evil is that good men and women do nothing. As well, I like the quote by Edward Everett Hale that says, I'm only one, but I am one. I can't do everything, but I can do something. And he goes on to say, and I will not refuse to do the something that I can do. Thank you for your attention. I'd be happy to take any questions you have.
We have microphones if anybody wants to raise their hand. Angela, you got one. Okay.
Hi, I'm Dorothy Jackson, and I have a question on the genetic studies that they're doing on Black women for maternity mortality. What can you tell us about those studies? Because they definitely think it's...
As I walk, I hear more my clicking of my heels than I hear your question.
Okay. the studies that they're doing on black women for maternity mortality, they think it's genetic that we have or missing that's causing more likely to be. So what can you tell us about those studies?
So I don't know if this is what you mean, but when you look at the weathering concept and we look at your chromosomes versus somebody else's chromosomes, we're born, we're initially created with the same chromosome. Number 21 is 21. Number 22 is 22. It has the same genes, all of them on it. But because of the stresses that you've experienced in life, those have been sort of chopped away. Your stresses may not be my stresses. My stresses may not be this woman's stresses. But now your genetic makeup is a little bit different. And those studies show that chronologically, based on genetic telomere length, that black women tend to be on average 7 years older genetically than white women. Other than that, race is a man-made construct. You're not biologically different because you're black and somebody else is white. We all have the same heart, same physiology of the system and everything. So it's not inherent to you that you're black, that you're genetically different. It's racism and the stresses that's been afforded to black women more than white women, as Michael Liu said, when he describes it in his article, like being followed around in a grocery store, in a department store. It's like being stopped by the police and your heart beating. You're wondering if you're going to be arrested for test driving a car. But anyway, I was arrested once for test driving a car. Treated differently just because of my race and the person I'm riding with. So those things are stresses that affect your well-being and affect your outcomes. So I'm not aware of any identified genetic differences based on just black versus white. Same thing with renal disease and hypertension. There's things that predispose certain people to different conditions based on their experiences.
Okay. And then I have another question.
Sure.
If anybody don't mind. So the White House, Kamala Harris, has taken this as one of her initials. So has any of those initiatives been rolled out in Indiana?
I'm not aware of any.
Oh, okay.
You know, there's attention to it. I'm not aware of that. I may not be the one to ask, but I was telling the group that I was with this morning that I was invited with 4 or 5 other physicians to talk about black maternal health, and I was asked to speak on the 5 leading issues affecting black maternal health, and we talked about different things, and each of the state Senate committee kept asking, what's the one thing we should address? What's the one thing we should change? And I said, there can't be one thing. We've been doing one thing for the last 2 to 3 decades, the last 20 to 30 years. It's all these social factors that affect things. And 20% of it is medicine, 80% of it is social issues that we need to address, like our voting rights and where my clinic is and what food is available to me and housing, et cetera, transportation to get to the things. So there's lots of factors that we may be trying to address, but we have not been doing that well for the last several decades. And I will say that out of that report, what they said was some physicians came and talked to us about maternal mortality or something, one-line sentence. It didn't really say, here's some things that they said we ought to address and things we ought to do. So state-wise, I can tell you that's what happened at the Senate committee hearing that I went to.
Oh, okay. My last question.
Sure.
Since you're part of IU.
Yeah.
I'm an IU grad. So my last question is, does IU Health has any initiatives that can be brought here to Fort Wayne?
I don't know exactly what's here in Fort Wayne.
Okay.
I will tell you that they have initiatives. We all have initiatives. I will tell you that after George Floyd was murdered, there was lots of attention and committees and DEI officers named. I know that there are some people that I know well who are hardworking, intelligent, driven people who are trying to address those things in Indiana. They're wanting to look at some evidence first and make some decisions, so that may be forthcoming. But I think there's some common sense things that we can address, and things we can say. People ask me, where should we start? Well, let's start by treating people the way we want to be treated and go from there.
Okay, we have another question over here.
Hi, I'm Cheryl Erickson, and I have a question. I mean, it's gone beyond implicit bias. You've got evidence. When I see 80% of African American or Black women have an 80% greater chance of admission after delivery, why aren't we doing home visits on every Black woman? To look at your evidence there's a path that we could do to change things.
I think there's a lot of common sense things we can do. And as I say, the better we make it for everybody, for my daughters, other Black women, the better we make it for everybody. So why don't we have home visiting nurses, not only for Black women, but for all women who might need it, who might be underprivileged or might need those resources. We can do a whole lot. Anybody who's had a baby knows how challenging it is to take a newborn home and say, I laugh and say the longest 2 days of my life were the first time I took my newborn home, and I was supposed to take it back to the pediatrician in 2 days. Longest 2 days of my life. And I'm an educated, skilled, have money and stuff, and I needed some help. People ask. I don't know who asked me. I think I was talking to a group in Rutgers, and they were talking about, how you feel isolated. Well, a lot of us get educated and we relocate. We're not near our families. I didn't have the resources of sister or parents or stuff to help me and to say, here's what's normal and not normal. Matter of fact, I had too many people telling me what was normal and not normal. And I was breastfeeding, and there must be something wrong, and there must be something wrong, and I had to sort of educate myself and read some books. And I'm like, this is normal, but it's frustrating. And until I called the lactation nurse, I called other people, it can be challenging. And home visiting nurses, I think, I'm back from the day when they had those. And that, for me as a physician, gave me some peace of mind that I had somebody checking on patients and knowing that. So, yeah, I agree. I believe in evidence-based medicine, but sometimes we've got enough evidence. Let's start doing something. I used to say, well, at least it's rhetoric, or it might be rhetoric, but at least it's the right rhetoric. I'm done with that now. I'm like, I need action. I need some changes because my daughters deserve it. And your daughters deserve it. Yes, ma'am.
Thank you for your presentation this morning. There are lots of the examples that you've shown, and I've heard similar stories here in Fort Wayne, friends, coworkers, African-American women treated so disrespectfully by our healthcare system. And my question is, I'm a woman of action, and I actually have a hard time sitting here taking this in because it's so heartbreaking. How can I help equip my friends and coworkers when I can't be with them every time, and I can't shout at the doctors on their behalf every time when they're in the hospital, when they're in the doctor's office? How can we help equip our friends and coworkers to get more effective medical treatment? How can we do that tomorrow? How can we make this actionable?
I think there's lots of different answers to that, and it depends on the situation, but certainly being open to interacting with people who don't look like you and come from areas that you come from, understanding what some of their backgrounds might be, understanding that what they experience and how they experience it and how they interact with it may be difficult. Being a sounding board for them, being an advocate too. I have people who call me and say, I'm going to the ER, or my mom's going to the ER with chest pain, can you meet me there? I had people from Chicago call me all the time during COVID and say, they just sent my mom home and she looks really bad. I said, tell them to ask this question. And when you pose the question where, okay, that does sound like you maybe have a little bit of education about it, or that doesn't make sense that I'm sending you home when you have the intelligence to ask me that. But some people perceive that as audacity, and so I show up. I've been in ER rooms and medical rooms where I'm sort of just looking straight down at my phone. I said, I wonder if maybe there's some other tests you might possibly do that could evaluate this or something, without saying I'm a doctor and saying, well, why aren't you doing this? Why aren't you doing that? But it's frustrating. And it's challenging, but we can't give up. We can't discouraged. We have to keep advocating. We have to keep talking to our senators. We have to keep advocating for voter rights. We have to keep advocating for housing districts and things that can improve for the patients that we serve. It's not a simple answer. It's daunting. It's frustrating. And as I said at one point, I was done. I was done. Been doing this for 20 years, and it's the same old, let's have a committee, let's do this and that. I'm doing things like this. I'm talking to people like you. One of you can help one other person who's gonna help one other person who's gonna help, and it spreads in that regard. I trust that God is in control, and that this will pass. Slowly but surely, but if I did not have faith in God, I would not be out here doing this, and I would have no hope for my daughters and for the community. But people like you and conversations like I had this morning encourage me to not be weary in well-doing, for in due season we will faint if we reap not. Yes, ma'am. Oh, sorry. Yes.
Hi, thank you. The weathering concept, is that permanent damage? Or
Yes. Yes.
So that's not reversible?
No. So that little 6-year-old girl started early with her drama and her, and just the mindset. It just irritates me. What does she think every time somebody looks at her sideways? I pray that she just got the energy and the thing to say, I'm okay. There was nothing unusual that I did there. We all have a bad day. Tantrum in kindergarten, and I'm taking you away. Anyway, I'm sorry. I got a little.
That's okay. I was just going to say I absolutely love.
Go ahead.
Okay, I absolutely love your idea of advocating. I'm a doula, and I love being in the birth room, advocating for women, and empowering any woman, I don't care what her race is, to own her body and her situation and become an empowered mother, loving her little baby. And I think that transforms society. And I think if we branched off into other areas of healthcare with the same concept, it'd be really cool.
I totally agree, and I'm encouraged by the group here today. And I tell people, quite frankly, it's going to take white people to say something to make this change. Kira Johnson's husband advocated for her all day long, and she was concerned. They're going to see you as a angry black male and put you out of here. How do you advocate, for a woman who's sitting there bleeding to death? It can be frustrating, and it can be challenging for patients, and how do they advocate for themselves? Doulas and stuff are great. Family members are great. It's going to take some effort. I'm sorry.
Good afternoon, everyone. I'm Dr. Regina Adair. I am an OBGYN. I've probably taken care of some of you guys here in Fort Wayne. But it's more than a question, but a statement. And Dr. Dungy-Poythress spoke about it a little bit in her last statement, but it is up to you all, the people that don't look like us, to make change. They don't listen to us, which is obvious. So the people who don't look like me and Dr. Poythress and the rest of us, it's up to you all to make the change, because you're the voices that they're listening to. So here you guys sit and you say that, this is deplorable, that this is absolutely ridiculous, but you all have all of the power to make a difference in the lives of women of color.
I just want to say thank you for coming and sharing this information. I think it's interesting that across all kinds of microcosms of our society, the racial disparities exist. And it goes to show, like you shared that video of the girls being ignored. I am a 41-year-old professional woman, and I still experience that on a regular basis, where I'm in professional context and I can see my colleagues greeting each other, interested in each other's lives, and I'm just a person a background person. So I guess what I'm wondering is if you can speak to how you've had to engage individuals, because I find that it's so easy for an individual to say, well, I'm not racist as an individual, without being aware of how their biases operate in larger systems and how they may or may not be contributing. So can you speak to any examples of where you've had progress on an individual basis with helping someone see their biases and how they may have implications systemically? I'm sorry, that's a lot, but it would be so helpful.
I can tell you that one of the reasons I started out with that fire picture, there's nothing offensive about choosing a red fire over a blue fire, but it shows you how your mind thinks, and I've got to decide quickly, and that it's unconscious, and we need to have attention to it. I've had discussions with colleagues of mine at the university where I've brought up situations. I told them about the time when I was arrested for test driving a car, and in the state of Ohio. And oh, by the way, it's illegal to arrest somebody for, it was for speeding in a test, on a test drive where the dealer had told me, go down this street, you know, and you can pick it up a little bit so you can see how the car handles, and then pass by a police officer who arrested me for speeding. And oh, by the way, it's illegal to arrest somebody for speeding in the state of Ohio. And so, so I was test driving a car, Toyota. To this day, I will not buy a Toyota. I have an implicit bias against Toyotas because of that. So, and I had just finished my fellowship. I was coming on staff with the University of Cincinnati. I was an assistant professor with the University of Cincinnati. I went out with my now cousin, who is my husband's cousin, who had introduced us, and we were test driving a car, and we turned a corner, and it was outside of Cincinnati, some sort of rural background, and he said, oh yeah, you can pick it up. And so I pushed on the gas, and I'm going this way. A police car passes us just as the dealer in the back seat said, well, you better slow down here. The speed limit's 45. So I slowed down. This police car passed us this way, turned around, and came back and stopped us. And I distinctly remember, I said, oh, well, maybe he'll understand we're just test driving the car. So he rolls down the window. I roll down my window. He comes up to the window, and he says, I need to see your license. I reached over to get my license, and he says, get out of the car. And I said, I beg your pardon? He says, get out of the car. I said, why do you want me to get out of the car? Get out of the car, or I can arrest you. Do you want to be arrested? I said, perhaps, sir. What I'd really like to know is why you want me to get out of the car. And he leaned forward and said, because I told you to. So I looked over at my now cousin and said, so what should I do? He said, I guess you should get out of the car. So I get out of the car. We walk back to his squad car. And he says, and he opens the back door and he says, get in. Have any of you ever been in a police car? I grew up in Jackson, Michigan. I had never been in the backseat of a police car until my friend and I, we went in college, we had studied, we had taken tests, we were going to walk to the mall. And it was about a mile to walk to the mall. And it was the coldest day of the year in Michigan, but it was the day we had off, and we had a little bit of money, and we were going to walk to the mall. And some friends of ours who were in public safety for the university passed us as we're walking down the highway, and they stop over and pull and said, what are you guys doing? We said, we're going to the mall. And so he said, get in, the coldest day of the year, you guys walking out here. And so when we get there, I go to open the back door to get out, and the door won't open. And so I said to him, you probably want to get this checked out. Your back door is broken, it won't open back here. And they all laughed at me, as some of you are, and they said, you've never been in the back seat of a police car, have you? I said, no. He said, no, the door's designed that way on purpose. You don't get out until we let you out. So when this police officer said, get in the back seat, I said, I'm not getting in there. He said, you either get in there or I'll arrest you. And I said, I'm not getting in there. Pushes me up against the car, handcuffs me. My cousin gets out of the front seat of the car we're test driving. walks towards the police officer and says, sir, please, sir, we're just, and he pulls out a gun and says, shut up and get back in the car. So he gets in the car. This police officer goes through my purse, takes out my license, and then shuts the door and takes me to the police station. And at the time, I didn't know where I was. It's somewhere outside of Cincinnati. I get in there, fingerprinted, picture, take a lot of information. And he says, what do you do? I'm a physician, where do you work or whatever? I'm a physician with the University of Cincinnati. So the reason that's important to me, and the reason I told it to my colleagues, is because it was a journal club, and I distinctly picked an article based on racial disparities and how stress for Black women predisposes them to preterm labor and complications. And one of the fellows that I was working with was a white female, and every time she read it, she said, wow, these Black women were still stressed even though they had a college education. They were still stressed. They said they were more stressed, as if that was fascinating to her. And so I told the story. And I said right there, when he asked me, what do I do? That's the only time my education came into play. That's the first time anybody knew how educated I was. When people look at me, they don't see my education. And so Black women experience things that have nothing to do, and that's why Black women, educated Black women, have the same risk of prematurity and complications as a 16-year-old, relatively uneducated white female. So that's why I told them that story. The story went on to say, he keeps my license. I have to come back to court for some reason, which when I got an attorney, he couldn't understand. Oh, but before that, I went back in because they give me this thing, so I need to show up at court on this date. I walk out and I realize I don't know where I am. I have no idea what county I'm in. I need to go back and ask them where I am so that I can call somebody to come and get me. And so I ended up, as I walked back in, what time do we need to end? Are we good? Okay, as I walk back in, I hear this chief or whoever, superior to this police officer say, are you kidding me? Are you kidding me? A physician? And so I just sort of pop in, I said, excuse me, I just need to know where I am so I can call somebody. So I call, find out where I am. I call the dealership to see if my friend is there, my now cousin. And so somebody gets on the phone, and I said, I was test driving with a car. I got stopped by the police. Then the manager, the overall manager of the whole dealership gets on the phone. He says, are you okay? I said, I'm fine. I'm just trying to find my friend. Are you sure you're okay? I said, I'm fine. I'm just trying to find my friend. Long story short, I get an attorney. He's surprised, one, that I'm arrested for speeding because it's against the law. He laughs. I said, yeah, that's all I was doing. And he said, it's against the law to arrest somebody for speeding in the state of Ohio. We go to court. The police officer is on the witness stand. He asks them why I was arrested. He says I was arrested because I refused to show my license, that I didn't have any driver's license. And so then my attorney says, well, when you put her in the back seat, you went through her purse, didn't you? He said, yes. And you pulled out her license, didn't you? Yeah. Then did you release the handcuffs? And he said, no. So she was still under arrest, correct? And he said, yes. And they said, and what was the charge? And he put his head down like this, and he said, speeding. And so then they pull in my cousin. He gives his testimony about what happened, pulls in the dealer who said, oh, yeah, she did give him the license, which I hadn't. I didn't have time to. He's telling me to get out of the car. So the judge says, I have no doubt she was willing to give you the license because this gentleman even thought that she had given you the license. I don't think this was about speeding. So you have my apologies. And so I told that story to my colleagues. And I said, and this was shortly after George Floyd had been murdered. So I said, I know from experience that police, one, don't know the law in their areas, and two, will lie about what happened. And to your point, I think it caught their attention. One girl started crying. One attending started crying. She is very attentive to things that I say. That may have been one out of, a number, but it's a start. And to share conversations and dialogues, to try to develop relationships where it's not, you don't have to tell all your personal business, but that's a story I share freely now because it points out that fact that not everybody who gets shot because you're so scared or whatever. My cousin could have been shot on the side of the road, if this gentleman had decided to shoot him and it was over something that was against the law for him to be stopping me for anyway. So I think that answers that. Did that meet what you wanted to say? And I have never been arrested. So I just thank you for the dialogue. What I love is the dialogue and the conversations, and I hope they continue. And I hope that we can address these things. Being isolated, being siloed, being quiet doesn't help the situation. We have to be a little bit vulnerable to share with each other the concerns and address and treat people the way we want to be treated. Thank you.
This has been wonderful. Another round of applause. Thank you. We want to show you a little token of our esteem, and I'm going to have Angela explain what we have for you.
So I really appreciate you joining us today and sharing your insights. So to share our thanks with you, we wanted to share a little bit of our community and our city. And Fort Wayne has a very thriving arts and cultural scene. And as part of that, people around here know the name Theoplis Smith for good reason. Also known as Fresh Laundry, Theoplis is primarily a self-taught multidisciplinary artist who's an active member of this community, and he's deeply involved in the performing arts and culture of Fort Wayne area. His latest murals are featured at Electric Works. His work has been recognized on a national level. It was displayed at the Academy of Motion Pictures, home of the Oscars, alongside award-winning director Spike Lee. And recently, Theoplis' work was featured on PBS NewsHour, highlighting his contributions to the art scene in Indiana. So, as our thank you, I would like to welcome Theoplis to present you with some of his work and to share with you his artistry.
Thank you. Before I share it, I want to just give some few things. Of course, thank you for the introduction there. In the climate and nature of today's event, me being a child and been creative since the age of 3 years old, my heroes I seen on TV became villains. I was a kid while drawing, seeing Rodney King being displayed in a not so good manner. And I wanted to make sure that everything that I touched, everything that I seen was positive, painted a positive picture and a realistic picture. So being an advocate for Black people, people of color, and everyone, that's what we do in the city. We want to make sure that we highlight those things and continue those things. So with this piece today, having a mother, having a beautiful wife, and having a 7-year-old daughter, I wanted to portray something that I think is fitting for the occasion for today even. And I present you with my piece called Sugar, Spice, and Everything Nice. And with this piece, you will highlight some things of a woman of integrity. And this is more so a statement piece, sharing and solidifying to just keep going. If you see in her hair, you'll see signs of like the actual honey and cinnamon, but also you see highlights of Shirley Chisholm, as well as Madam C.J. Walker. Also, you see a scripture from the Bible where it's highlighting Proverbs 31, indicating the tailor-made experience of being a woman of God. So with this cornucopia of things in her hair, you display these things I've seen these things, and I'm honored to be able to share my gift with those who are in like-minded spirit. This is like an iron sharpens iron, so keep going. Thank you for being here, and it's an honor. Also,
We have refreshments for everybody outside. We welcome you to stay, discuss this a little bit further. I know there were more questions and views, but please take some time and think of how we can all make a difference. We also would invite anybody to sign up for at the entrance if you want to come to any of the future prenatal and infant care workshops. We also have free directories on resources. That's always a question for people. We have they're free for as many as you need to get them in the hands of new families who need anything from diapers to healthcare to dental, whatever they might need. So thank you for joining us. Thank you so much for coming to Fort Wayne.